super excited to kind of start this conversation about the report that Chris and Peter were involved with. I'm just going to kind of pass it on to them. Chris Cowley and Peter Athanasopoulos, welcome. They're from Ontario, so a few hours ahead of us. And thanks for being here. And I'm just going to hand it straight over to you.
Hello, everybody. And actually, I'm from Manitoba, so it's not quite as late. Just as background, I have been living with spinal cord injury since 1987, and I did spend some time as executive director of the CPA, well then CPA, in Manitoba, which is where I was not. For those two reasons, I've been sort of always wondered how things work in terms of reimbursement and coverage of things that are considered essential. And then I also do research at the University of Manitoba, which is why I was involved with this. And the only other thing I wanted to mention is this sort of came up during the pandemic because Peter and I were on the same committee across the country. And it was when, in response to the pandemic, we were seeing that there was so many gaps and differences across the province. And that's sort of what led to this investigation. And I'll let Peter introduce himself, and then I can just tell you what we found.
Hi everyone. I work for Spinal Cord Injury Ontario. I'm the Director of Public Policy and Government Relations. So a lot of my role is to take evidence-informed research and do my best to collectively put it into practice through either a policy change, a practice change, or creation of new programs in government. So I spend a lot of my time lobbying elected officials on work that you're going to hear about today with hopes that we could create better coverage programs for people with spinal cord injury.
So what we did for our study basically was we wanted to think, well, what are the things that people with a spinal cord injury need, and within the constraint of the universal healthcare system. I know that this focuses on catheter coverage, but it was one of three that we actually looked at, because we looked at attendant services for activities of daily living, and we also looked at assistive devices for mobility, but in particular, just focusing on the coverage for power and manual wheelchairs. So that's what we ended up looking at. And we did it in two ways. We did this environmental scan of all of the policy information that was available online, and then we backed it up with key informant interviews. And those were really important because they allowed us to actually talk to people in every province across the country who are like on the ground and working with people in terms of either having a spinal cord injury or providing peer or other support or counseling support for people with spinal cord injury. So we did that in all 10 provinces. We didn't do the territories, and part of the reason for that was because we didn't actually end up being able to find key informants in those regions. So that was a sort of a failing of what we wanted to do. But when we looked at it across the country, if you look, most of the countries means test for healthcare, and they do it in different ways depending on what the product is. So, and by means testing, what we mean is that in order for you to receive this item, they will assess your financial need for it. So unlike, when you go, if you're having a cardiovascular event and you go to the hospital and you need a stent put in your heart, they don't ask you how much you make before they tell you how much you have to chip in for it, right? So we wanted to look at the policies and how each of those policies are different in each province. And it was very interesting because even in terms of bladder and bowel care, it was interesting because the terminology that people use, like in BC, they would indicate that it was a catheter, a device for draining the bladder, whereas in the Atlantic provinces, it was often referred to as incontinence supplies. So you turn something that's a medical need into a social problem, depending on your language that you're using and the policies that then support that. So the only province that doesn't means test for can you see my pointer or no?
Yeah.
Oh,
Yeah.
okay. Okay. So the only province that doesn't really means test for bladder supplies is Saskatchewan. All of the other provinces means test. And so, like, as you guys I'm sure know, in British Columbia, these are covered, but only when you're on social assistance. So as soon as you start earning any money, then you're not, then bladder and bowel supplies are not covered. And then it was also similar for wheelchairs, because even though I think there's a fairly wide variety of wheelchairs that people can access, but there's no program for people once they're off social allowances. And it was interesting because even there's a lot of health policy information online in BC, and it was quite striking because they would say prosthetics are covered, smoking cessation things are covered, all of even opiate addiction withdrawal items are covered, but it explicitly said wheelchairs are not covered, which is interesting because how do you define that? Or how, on what grounds can you say that that isn't an essential need? And whereas things like breast implants, replacements, like when you have breast surgery, the breast implants, those were actually funded under this program. And they were funded under sort of a high cost program where you would only pay up to a certain amount, which was not very much, for very high cost items. And then after that, the healthcare system would pay for the remaining portion of it. So that is sort of a little focus on what we found as it relates to BC. And then it's just, there was such wide variability. It was just crazy. And the financial implications to people, like the things for attendant services, for example, it's means tested in 5 of 10 provinces. And, you know, in the Atlantic provinces, you might be paying like 18% or 42% of your income at fairly low levels for attendant services. And when we did these calculations, we did it based on, you know, 10 hours of care a week or 15 hours of care a week, which really isn't that much. And it was only for activities of daily living. It wasn't for like housekeeping or anything like that. But we don't need to know of all the details of it. But the other thing that some provinces did too is they also charged you a fee that increased as your number of attendant care hours increased. So for BC's perspective on this, it did use a ratio, but it also topped out. So it wasn't that bad compared to other provinces like Saskatchewan or the Atlantic provinces as far as attendant care is concerned. And also, I don't know if people want to ask questions or whatever, like if you interrupt me or tell me to stop talking at any time. So we found that for the other thing we found about in terms of attendant services is that, as I'm sure people who use attendant services know, that, you know, there's quality controls lacking. There's less access in rural regions, Indigenous populations, and depending on where people are living, they can't get access to trained workers. And then that's, of course, why we've got these alternate delivery models in terms of self-managed care to try and address some of those things. And the other thing that we found is that it's extremely complicated in terms of the financial assessment. So, you know, in British Columbia, for example, they use a very detailed formula, and it's based on your family income, your various allowances for non-earned and earned income, and your RDSP contributions. And it actually used to be that you'd have to start paying down your RRSP, that actually should say your RRSP in order to be eligible. But they've recently increased the limit, I think, to 100,000. So you basically had to get into poverty before you could request any support from these systems. And this is just summarizing it for all of the other provinces. But moving on to the neurogenic bladder and bowel supplies, those were means tested in 9 of 10 provinces, as I mentioned, all except Saskatchewan. And I did mention how it works in BC in terms of the cutoffs. And the other thing that seems very strange when you think about this is how much red tape is put in place for something that's a relatively low cost item. So, and the other thing, as far as the bladder supplies is concerned, the levels that are covered are often not sufficient numbers to be able to cover the number that you would need per day for single use, which is what's recommended by the Canadian Urological Association. And also, sometimes it was stipulated in the policy that they could only support the cheapest product available. And that, of course, is very counterintuitive, but it's written in their policy, which means you might be forced to purchase non-fire polished catheters, for example, which then leads to urethral scarring and tearing and damage to the urethra, which could result in surgeries that are complicated and very expensive, rather than paying for something that's going to reduce your risk of infection and also reduce your risk of injury. So that's basically the range of funding levels that they had. And other than Saskatchewan, that was the only province that would potentially had the right type of policy that would allow reimbursement for those supplies. And this is all just way too detailed. I don't want to talk about that, but there also, the other things as it related to wheelchairs is that there's shortages, there's exorbitant wait times for assessment. It's means tested in 4 of the provinces. And then, as I've mentioned, they usually say the most inexpensive suitable option. And they use a loan-based system in 6 of the 10 provinces. So rather than providing it as a purchase thing for an individual, to fit your unique physical and functional needs, rather it's from a loans-based pool. And some of those are administered by charity organizations, which is the case in Manitoba, New Brunswick, and Nova Scotia. Whereas in Alberta, Quebec, and Saskatchewan, they're administered by provincial health authorities. Why that's important is because if you offload this to a charity, you also offload your responsibility for it. So, and then there's a bunch of variety about what they will cover and what they won't. So for example, in Manitoba, you can get a wheelchair loaned to you, but they don't provide cushions or backrests. So you can get the chair, but if you don't have a cushion or backrest, you have to purchase that yourself. So there's just such wide variety across the country in the different provinces and there's huge inequities between them, and then inconsistencies in terms of, the different areas that are relevant to people with spinal cord injury in terms of attendant care versus bladder supplies versus wheelchairs. And then we also found it was extremely difficult to access. And there was a lot of administrative red tape that just didn't seem to be helpful. And Marnie, you were going to say something?
Yeah, so are you saying that it's better to have the charity do it or the government for that last?
Well, I think, in our province, I think it's worse because it offloads that responsibility. So then they say, well, we gave them money and, we've given them an envelope. Now you solve this problem. And in Manitoba, when you look at the financial report from the SMD, but it's Manitoba Possible, the amount of dollars that they, for their whole program, because they have an annual report and they state what their income is and what they use it for. But the average per person cost for the number of people that they say use their wheelchair program is about $350 a person. So there's no way that is effective, or that $350 would buy an adequate or appropriate wheelchair. But they pride themselves by saying we provide a wheelchair to every Manitoban without means testing, but they do it by saying, if you need a manual wheelchair, you can only get this one type. And then they buy it from the supplier at a very reduced rate because they're only buying one type of wheelchair, but a large number of them. And they do the same thing for power chairs too. So they restrict your access by saying, oh, it's not means tested, but you can only have this one chair. And anybody who has any ability to do so immediately goes outside of that system as soon as they can because the chair is inadequate. So that's so and as far as Ontario, not Ontario, but Atlantic Canada is concerned, they might have a bit of a better program, but the details of it was hard to assess that because we didn't see. And I'm speaking more about Manitoba because I am aware of it as a user and a person who's lobbied the government for years to try and change that system. So but yet on paper, they can say that we do provide wheelchairs and we don't means test for that. And then the other thing that we found was, it wasn't really the policies aren't outcomes or evidence-based, and they're not standardized within or between provinces. And there's a lack of transparency in terms of their service delivery and their outcomes. Like, are they effective? Are people getting sufficient visits for attendant services? And, how long do they have to wait for a wheelchair? How long do they have to wait for repair of a wheelchair? Do they get backup equipment? Like, is it happening in a timely fashion? So all of those things, there's not really very much mention of how the system is working for these people. And the other thing that we found sort of summarily throughout is that despite their lived experience, people with spinal cord injury were basically just passive recipients. And often then in Manitoba, for example, you require an OT to get a prescription for one of these loan chairs. And if they don't have it in their equipment pool, they will buy one for you. And that's usually what happens for people with spinal cord injury. You get a bought one, but they don't require the professional OT to have any experience at prescribing a wheelchair. And so therefore, any OT is not going to give you a good prescription for a wheelchair if they've never done it before. So there's problems with that. They put it so that the system is over professionalized, but maybe not having the expertise they need to deal with the issues that are important for people with spinal cord injury. So that is a very quick summary of this, but that's what we did. And yeah, and I know our focus is catheters, but we can talk more about that with questions and stuff. I just thought I'd give that little speedy introduction.
Awesome. Yeah. Thanks. Thanks, Chris. Peter, I think probably what the group would love to know is, because you have put together a campaign before for Spinal Cord Injury Ontario, which was unsuccessful. So maybe if you could talk a little bit about that, but then also how this work is helping you and what your next steps are going to be for getting catheter coverage or any of these other things that Chris is talking about.
Sure. Well, I will focus on catheter coverage because that's the topic of today. But if anyone wants to follow up with Chris and I on additional information on any of the other aspects of this work, we're certainly more than interested to connect back with anybody and share your questions. In terms of catheter coverage, what stems to be the largest challenge to overcome is the fact that IC users are a small population and the cost of catheters are really high. So if I look at just Ontario numbers, because I know them very well, is on average, like it is expected based on the best evidence available, there's approximately 40,000 people that require intermittent catheterization in Ontario. And on average, people need about 3 to 5 catheters per day. And on average, it costs a person anywhere from $500 to $1,000 a month to pay for their catheters. And on the high end, it's about $2,500 per month to pay for their catheters based on different complications. So what that translates to is approximately $100 million a year to solve a problem. Right. So when you're looking at the prioritization of all the healthcare system, where the government is putting its dollars to maximize the largest volume of support, and recognize this has to do with votes as well, right? This has to do with elected officials approving programs and services that have the highest volume of support so people can remember them when it comes election time, right? These are the factors that are built into trying to get a coverage program passed. So some of the things that we've done, and I know we're still working on it. I would not say what we're working on in Ontario is unsuccessful. We've just gone through a couple rounds of budget submissions to be able to get to the place where the government can understand where the true opportunity is. And what the true opportunity is, the cost of doing nothing, right? Think about the complications involved when people are reusing catheters, when people have to go to doctors more often than not for a urinary tract infection, when people have to do surgeries and other invasive procedures that were complications from the fact of not providing the best gold standard urinary product that people deserve. So that's been more the tangible piece of where we've been having more meaningful engagements with the Ontario government. And now we've gotten to the point where we've provided multiple different models to the government on how to support different ways. So for example, we know that the Ontario government funds people on social assistance with intermittent catheters, right? And we know that of the 40,000 people, that's 70% of the population, right? So really we have a 30% problem, not a 100% problem. And then if you break down that 30%, 5% of those 30% actually have full coverage through either auto insurance or third-party insurance or WSIB or workplace benefits. So really the problem that we're actually trying to solve in Ontario is that 25% who get absolutely nothing and no coverage at all. And we've done a series of health economics to try to translate what that 25% converts into dollars. And through a series of modeling and health economics, we know that that number equates to approximately 3,000 people at approximately $10 million a year, right? So, and that's the reason why it's not so clean mathematics and it's a little complex is because you're also looking at what type of catheter they're using because the costs are different. You're also looking at, the spinal cord injury population, which is 90% of the IC users in Canada, and looking what bladder management they're using. Some are using condom catheters, some are using Foley catheters, and we're specifically narrowing on intermittent catheters. So we now have a viable proposal that even though it's only for 3,000 people approximately, but $10 million a year in a $90 billion budget is something that you can find, right? And that's what we're working within our government with is how to viably find a mechanism outside of social insurance and our social assistance and outside of insurance to be able to pay that program. And we have a variety of different models that we've been presenting. One of which is for Spinal Cord Injury Ontario to run the program for them on behalf of the Ontario government. So looking at unique ways to do these things. In our province, children under the age of 16 are funded through Easter Seals, right? The government of Ontario provides a transfer payment agreement where they provide annual funding to Easter Seals Canada that funds incontinence supplies to children who need them, right? So in our province, we're mimicking what that looks like in terms of dynamics and trying to create that change in that manner. We're really close. There's some obstacles. Government's always a challenge. Political will is always the highest obstacle to overcome, right? You need a champion in government that says, I want to change this with enough clout and decision-making authority to engage cabinet ministers to make a change, right? That's how these things work. It doesn't matter which province you live in. That's essentially the key ingredients is getting the political will through a champion in government that can push this through the decision-making authorities. But that doesn't mean that's the only thing that you have to do. Government relations is not the only solution to this problem. There's many ways to tackle this thing. And one way is, essentially collaborating with elected officials to say, you want this to be your decision on whether you vote for them or not, right? So in determining your position as a citizen of this country and this province, how you want your elected officials to be voted on. So essentially making promises in their platforms when they're reelected. Another avenue you can take is a large-fledged campaign, which we early on did to get the attention of government, which gave us the open door to have meaningful conversations. So we launched a campaign called P for Free, and we put it in billboards, we put it in subways, we put it in bus ads. We had multiple sponsors involved in it because they believed in the notion that people in Canada shouldn't pay to go to the bathroom. And that campaign sparked a lot of attention to get us into these meaningful conversations. The third piece, and it's an individualized piece, it's not a piece that an organization can do, it's a piece that you as an individual can do, is consider this as a human rights issue. In Canada is one of only 2 countries in the world that is an outlier and forces people to reuse catheters. We, in fact, have policies, as Chris explained, that says we're only giving you a number of catheters per day, and you figure out how to go around your own business for the rest of it, which is essentially taking a single-use product that is approved by Health Canada for only single use, and then having clinicians telling you that since you have no money and no coverage from the government, you have to boil these, microwave these, or figure out your own way of cleaning them and reinserting them in your body. There is a meaningful and there's a meaningful case to be said that you can go to a human rights tribunal and plead your case. In fact, interestingly enough, 20 years ago, the reason why Easter Seals Canada has an incontinence coverage program is because parents of children sued the Ontario government, and part of the settlement agreement, it was that the Ontario government had to provide incontinence supplies to children because it was inequitable to adults. So it wasn't Easter Seals Canada that applied for this funding. It was, in fact, the fact that it was part of a settlement agreement. So in summary, there's three things that you can essentially do: is mobilize your community and have meaningful conversations with elected officials. You can mobilize your community and engage in an awareness campaign that really speaks to the general public. Do I really live in a society where people have to pay to pee? Or you can take individual actions and look at the legal and human rights tribunals as an avenue in which you can bring change towards an inhumanity and an undignified approach, an undignified situation that we're all currently in. Happy to take any questions. I know there's a lot to absorb there, but hopefully it was meaningful.
I know Andy's got some questions. He's writing it all down. He's leading our project here. So
did you just notice that I put on unmute? Yeah, that's great information, Peter and Chris. Thank you very much. There's a couple. The first question I have was when we talk about the true opportunity and the cost of doing nothing. Did you have any kind of hard factual numbers from, let's say, using as Ontario as an example in terms of, my question is, how do I identify the cost of missing, or the true opportunity in terms of what is spent from people having to go into a hospital with UTIs, prescription costs, lost time from work, so be it, that sort of thing. Because I kind of really believe kind of the more hard factual evidence we can have, the stronger our case would be. So did you, because I have heard some numbers bounced around a little bit, and my initial reaction is, holy smokes, that sounds like an awful lot of money, right?
Yeah.
For somebody, just like even an emergency visit, when I hear about it. But
yes,
I think, and I love it used that way, the true opportunity, the cost of doing nothing. I think if we could get, and for us at a BC angle, to try and find some costs that are, they don't sound like we're ballooning them for our own personal interests. They are can be, kind of backed with some fact behind them.
Sure.
Did you guys have any kind of numbers to come at the government with in Ontario in terms of?
Yeah. So there's two ways of looking at this. Is number one is, view the ministries across the government as individual organizations, right? So the Ministry of Health is looking at cost savings to its own budget, not to the government, right? So you have to look one-to-one, right? So for every dollar they spend, how much dollars do they save in the downstream? So that's like the most important piece to do, right? And we can
Yeah.
give you some numbers around what the health utilization costs look like in Ontario. And we actually have a health economist that if you were to create some assumptions, like, so what I mean by assumptions is you have to predict, well, what are these costs, right? So what does it cost for a hospital bed? How many times do a person with a spinal cord injury go into a hospital bed, and work with certain researchers? I can give you our algorithm that we use, and then we can, then you send it to a health economist, and then they kind of use evidence formulas or algorithms that they use with government to predict those outcomes. So that's how we did it. There is a cost component to that, unfortunately, right? Like you have to hire these firms to be able to do these things for you. But I can hand you what we got. It's
Sure.
published knowledge, right? Just to give you a sense. But the other opportunity is, thanks to some of the work that's going on at Praxis Institute, Spinal Cord Injury Ontario and Praxis Institute have are funding right now. We're in the RFP process. An opportunity where we're going to hire a health economist, and Chris and I are going to lead a national health health cost benefit analysis that should be able to benefit every province. Where we'll work with this firm once identified, and once they start getting going around, well, what is those cost benefits by province, and what is the algorithm nationally for a standard of practice. So then not only will we be able to engage Health Canada, the provinces will be able to use the data in a way that can have meaningful conversations around return on investment to government for simply just covering catheters.
Sure. No, that sounds perfect. It's funny because a lot of this, even when you go through the awareness campaign and all that, like for the billboards and that, I'm thinking, okay, all that's going to cost money in terms of how did you fund that in the province
We
of
raised a
Ontario?
lot of money to do it, right?
Did
Like
you?
we worked with corporate industries. We worked with individual donor campaigns. Um, recognize SCIO has been doing this for almost 6 years now, right? We've been scrounging every dollar we can find. And we've also been fundraising to pay for the supplies too, right?
Sure.
So, we're engaging donors to help us in the now and in the future, right? So as you probably know, December 3rd was Giving Tuesday, which is a charity day every year where people donate to charities of their choice. We surrounded our Giving Tuesday around creating enhancing independence funds, is what we call it, where when people don't have the funds to pay for some, we just pay it for them.
Okay. That's great. That's really good. It's funny, as I'm talking, I'm looking at all the notes I was trying to scribble down here. One of the things, and I think it was quite a powerful statement that you mentioned, Peter, was with the human rights issue, and that Canada is an outlier. Do you, I think that's that speaks pretty loudly in itself. You wouldn't expect our country to be an outlier in something like this. You would expect us to be kind of a leader in it. Where do you get like, is that list, is that published in terms of?
Yeah, I can provide you that report. That was one of the first reports we did in like 2015. It was a while ago, where we looked at all the developing countries around the world and actually looked at whether they're forcing the reuse of catheters or not, by simply how their coverage programs work. And of the developing countries, there was two outliers, Canada and Argentina. Every other first world developing country had some universal coverage. It was means tested, but it was mean tested against giving people what they needed versus saying we're only covering one catheter a day.
Right, right. Yeah, and I know it's kind of I'm very much in the infancy of trying to get this going in BC, and then you had I kind of for us you had mentioned it really helps to find a champion in government to help push through those issues with this. So I think that's one of the things that we've got to identify if we can get a champion or one or two, MLAs that are in cabinet now to kind of help us push this through and work, all the channels that you need to in government. The other one was for, the awareness advocacy campaign. I was kind of leaning on, again, thinking more on having a smaller budget and using a social media vehicle.
Yeah.
I used the example in our last call. There was one just previous to our provincial election that I can't remember whether it was the Royal Canadian Mounted Police or the police union, but they wanted bail reform to be something that was important to people, and they wanted to get kind of people to go online and support them with kind of
a real cheap way of doing a strength in numbers campaign is leveraging change.org, right? So recently our City of Toronto municipal government was doing a whole bunch of reforms around wheelchair accessible taxis. Rather than us having to pay a lot of money and build a campaign around that, which is a finite time where they were reviewing the regulations over 2 months, we built this comprehensive change.org campaign, and we gave it to all our constituencies. We built the whole rationale behind the general public, more so than just targeting people with disabilities. And it became the most popular website throughout the entire review, where people were providing messages, comments. I can send you the link so you can see
that would be great.
From another campaign point of view, how something can be hugely successful. And it's free.
Right. I think that'd be perfect, because that was part of, what I was saying is we've really got to get the able-bodied community to stand behind this message also, because, like you said, politicians are interested in votes. Yeah. We're a very small number of people. But I do think most people aren't aware. They have no idea that people are saddled with this financial burden, not only catheters, but wheelchair access. If you look at what the modifications you have to your house, driving your vehicle, it's on and on and on and on. And to many people, it's probably one of their worst nightmares, or one of the things they worry about with them or their children. So I do think that if people became aware, I think politically we would become a force for change.
I'll tell you, after we finished our campaign, some of our counterparts in Alberta met with us and wanted to use our campaign, and we absolutely gave them everything that we had. They converted their campaign from P for free to pay to P.
Right.
And in a matter of a month, we worked on it 6 years, and in a matter of a month, they got their coverage program changed.
Yeah, and we had Bean talk to us at one of our conference calls.
So it's a matter of being at the right place at the right time.
Yeah.
Right, with the right person.
No, I think that's what they did is definitely truly remarkable. I don't know whether their timing was perfect, but they were successful. The other thing that Chris had mentioned too is of the provinces that do provide financial support, is you've got to use whatever catheter they feel their budget allows. And I think, if we had a program like that, I think you'd find people, myself included, that probably wouldn't use it. So it really doesn't help me, and it might not help a lot of people. I can see that being an option for, social assistance angle, but I think what I would like to see, even if we can have a hard number that people have to pay on average for catheters, if they come in at a 50% support, that's better than nothing. And and I would really like to push for, when we get this thing moving, kind of that's really not a solution that we're interested in, because everybody has different needs, products that work best for them, and I think to have the freedom for people to purchase what they want, whether that would be to, claim monthly at the end of the year, however it would work.
Yeah.
You
The issue with me is, sorry, Chris, one last point. The issue with means testing, the issue with lowering the coverage to be able to provide something to everybody, the consequence to that is that there isn't a great return on investment to do that. So when you look at what the government is spending and what they're getting in return for spending it, if they means test it so much, people are still going to go to hospital. People are still going to be going to emerge because they really haven't solved the problem. They just trickled some crumb money at it to make people happy, and the problem never really went away. So the return on investment doesn't help the taxpayer nor the coverage program. So that's something, and we kind of learned that the hard way. We thought, we brought this down to 25% of the population that we were going to help, right? And then the government turned around and said, well, we don't want to give you 100% coverage for that 25%. Would you consider 75? And then we were like, if we go lower, then the government's going to gain nothing because we're not solving the person's problem. We're just giving them a little money, but they still have to solve the rest of the dollar value.
And you're also adding to the administrative nightmare of administering that problem in terms of those costs as well. But the other thing too, in terms of guidance, as far as catheters are concerned, you could go with like the Canadian Neurological Association's recommendation, which is, and that's in that report, but we can also send you the reference itself. But they say for those with neurogenic bladder, they should be using hydrophilic single-use catheters, and that's would be sort of the top end. And addressing the quality of the catheters, this should not be left up to the purse string people. It should be left up to the physician who determines that you have this need.
Yeah, right.
Because our province of Manitoba doesn't tell the cardiologist what type of stent to install.
Yeah.
Right.
Exactly. Yeah. And then like the proposal we put together was driven by clinical prescription, right? We can't say, like, we think it's so wrong that say we'll only cover 2 catheters or 3 catheters, because that's implying that you don't need prescription for this.
No, that's also true.
Interesting.
I have a question, if that's okay, Andy, unless you have more. Okay, good. A couple questions, actually, Peter, for you. Well, actually, Chris, too, if you have answers. So one is, have you considered looking at other populations that use, yes, you're nodding.
Yeah, so our Essential Needs project has 3 phases. We've just published the first phase. We're working on finalizing the second phase, and we're starting the third phase, right? So the second phase of Chris and I's project is to look at 7 different countries around the world with similar social systems as Canada, and compare how they've built their coverage programs, as well as doing key informant interviews similar to what we did in Canada in those countries, so we can get a cross-section around the diversity between provinces in Canada and the diversity of various different countries that are doing far better than we are, and how they've come to resolve their coverage programs. Chris has more details around the nuances between those countries. So is there anything you want to add, Chris, our preliminary learnings?
Not really, except to say that I think that the Northern European countries are the best in terms of what they do and how they consider this as it relates to catheters. And just like we saw within Canada, the countries that are the best for these things vary depending on what the item is. So like the UK is not too bad for wheelchairs and catheters, whereas other countries like Belgium might have good wheelchair and catheter coverage, but then not provide any attendant services. But as far as catheters themselves are concerned, it's basically the Northern European that have got the best systems in place.
Yep.
And
And
France.
just
Oh, and France also is one that
France
did
probably has the
economic
best coverage system. Yeah.
Yeah, and they did an economic analysis and wrote some papers on that. So we do have those, and I think they are cited in that report. And if they're not, they're cited in our publication, which is still being reviewed for publication.
And what about disability populations? Like, have you looked into like the aging population? I know Andy at one of our calls mentioned like people who have prostate cancer, you know, sometimes have to use or go to.
Yeah. So
Yeah.
we in Ontario applied for a health technology assessment, which I think every province has some level. I don't know what they may be called differently. It's when you ask your Ontario government to assess a technology, and they go through a comprehensive research review and looking at their population and different evidence that supports those different cohorts. We particularly chose to stick to neurogenic bladder, um, and anybody that needed a catheter for life, permanent. Um, we felt like we didn't have control of like people that needed only a catheter for 6 months and didn't need it. There was just too many variabilities, even in the health economics. You know, pregnant women use catheterization during pregnancy. People with cancer challenges are using catheterizations. There's different aging, bladder, prostate, issues and such like that. So when you looked at that variability of that short-term need, we concluded that we were going to leave that to the hospitals, because hospitals have their own procurement with the government to purchase medical supplies for while you're in hospital, right? So we decided, since those are short term, and they didn't fit our definition of permanent, that we would not focus our energy there.
And then, so just so I understand, you decided to just establish a, for lack of a better word, campaign or whatever, just for intermittent catheters, just to make the market smaller, essentially, so that the government didn't look at this huge.
Yeah, well, when we completed the health technology assessment in 2006, 17, 18, the number was so astronomical for one catheter a day, because they looked at the entire population side. Like, it was like a non-starter. We had to try to bury the report before use the report, right? It was so off base because the population size was so larger than neurogenic bladder that it became a barrier for discussion, because every time we engaged the government would say to us, well, we have the health technology assessment, like this is beyond our scope of being able to afford.
Interesting.
So that's what started the whole dwindling down to what specifically are we asking for, that we think the government would be able to prioritize.
Megan?
Oh, I know. Has there been any discussion with the actual providers, not providers, but in terms of lowering the price of catheters, like a pharmacare, but for peeing, you know?
Yes. So, you know, there is some programs there where they have to do fixed pricing with the manufacturers directly, right? So I don't think any of the industry providers, if it's a government program, would move away from fixed pricing. I think that's not the problem, right? I think if government wants to do that, they can negotiate a less than retail price, and all the manufacturers would be on board with it.
Okay.
I don't think that's the challenge at all. With the volume of a government program, which gives the product security, I think their profit margins would be just fine.
And I have one more quick question to go along with that. Has there been any discussion about bowel products, or is this entirely catheters?
So we focused on intermittent catheters only because it's the gold standard bladder management system, right?
Right.
And we needed to get over the finish line to be able to then introduce other things like bladder, like condom catheters or other bladder systems that we can incorporate. We felt that the transfer payment agreement to SCIO was the most flexible way where we could negotiate a program while running a program, as opposed to, you know, the government running the program and then trying to fit new prescriptions in it. But that's notwithstanding that we actually went to the government first for them to develop their own program, and the challenges we were facing around the government's overhead to administering their own program or their existing program um, didn't have the space or was not fitting their definition. So we originally wanted the government to do this. The opportunity for us to put a transfer payment agreement proposal together was simply to try to make it easier for the government. We don't care what mechanism they choose. I don't care. It doesn't matter to Spinal Cord Injury Ontario if they're the bursary program. We're just trying to help them find the easiest path to get this funded. And if it's not us, that's no problem. We still think it's a win.
Yeah.
And I think that's the negotiations that you're going to have to figure out with your province is what existing programs do they have? Where would this fit? If it doesn't fit, would you be willing to build a new one?
And
if-
also,
Yeah,
yes, sorry. And also, how does it relate to other programs that you can speak to? Like what
that's
the
right.
example that I gave about wheelchairs versus breast replacement. And I'm not saying that you shouldn't fund breast implants for cancer, for breast cancer, but if you can use their own documentation that explicitly excludes things, which it does, right? Because your own documentation does provide catheter coverage, but only within that means testing realm. So, and then you would put it to the government to say, why is this not an essential medical device that's required?
Yeah.
Yeah.
I was going to say another avenue that's worth exploring is home care, right? As the mechanism for paying for medical equipment, because they do provide prescription in some which way or form for those that have nurses or other healthcare professional teams that are coming to your homes with helping you with certain medical needs.
The only problem with that one though is that's how it operates in Manitoba. If you get home care, all of your catheters and if you have ostomy supplies or anything like that, that's all covered by the province 100%. But only if you're getting home care.
Yeah.
So if you don't have home care, like I don't, for
But what
example.
I'm trying to describe is home care has a mechanism to already procure and disseminate.
Oh, I see what you're saying.
You can apply to home care without providing direct service to them, and they already have an existing program which they've already procured that they can extend beyond those that they only have to visit. It's a matter of finding the simplest way for government to add money to without spending a whole whack of money and administering new programs.
Well, can I ask a question as it stands now? When in the reading that we did, it looks as though there's like a warehouse where they get medical supplies like catheters. If you're on social assistance, is that and you get a supply for a year, I think it is, and you have to renew this prescription. Is that accurate?
I've never heard that. Is that in Ontario or somewhere
No,
else?
in BC. I'm asking about BC.
Oh, okay.
And it's only for people on social assistance, as far as I understand.
That's correct. I think so.
Yeah. Okay. And do you have, the reason I was asking was because I think they then just reimburse it, right? But they have it through whatever the social assistance program is. I wonder, in this I know Peter said that health doesn't care what social services is spending, but if they've got a mechanism where they approve it once a year or whatever, and then you have your where you can go to get these supplies, like that procurement mechanism is in place also within the social welfare system. So maybe,
Yeah.
there's something that link between those.
That's right. That's right. Um, it's always disheartening that we have to figure out how the government works in order for them to figure out how to spend money, right? You would think that you can just recognize a problem for them and they would go back with their many staffers and say, well, where does this fit? Um, but it's not been so clear cut in our process for them to just go back and figure out how a solution's been found.
Peter,
Yeah.
you had mentioned three little points here, and the first one was a champion, in government. The second one was the awareness advocacy campaign, and the third was the human rights angle. Pushing for change in Ontario. What would you say, based on your experience so far, what would you put the most attention towards initially starting out?
Because we've gone lots of rounds, right? We've done 3 budget submissions. We've done a fall economic statement. We've met directly with the premier. We've met with 3 different health governments. We've met with finance. We met with the Treasury Board. We've met with seniors and accessibility. There isn't a person in government that hasn't an influence on this that we haven't met with. And right now we're in the budget process, which is near its completion, and we're in the prioritization stage. And this is our 3rd cycle of budget submission formally to the Ontario government. So we could get a miraculous win in the next couple months or so. And if we don't, I don't know as an organization what more we can do as a public policy department. And I don't know how outraged further our community has become to the point where they're going to start taking matters into their own hands. And if that happens, that's out of our control. We as a charity don't engage in those matters. We would not engage in any human rights issue. Those are individual issues. But I can tell you in Ontario, they're ready to happen.
So Peter, do I understand you correctly that none of the organizations wouldn't be in support of us showing up at the hospital with ski masks on, stealing catheters, and getting arrested, and see how where that takes us?
I wouldn't wear my corporate hat when I'm doing that, but I've also been living with a spinal cord injury for 30 years, and if you want me to shackle myself in front of your health authority, I probably will join you.
Sounds good.
Because that's kind of what I'm thinking right now is I think there's been a lot of, we're really aware of the issues. There's been a lot of study and stuff put in. I think the only thing maybe missing is we're not pushing the government hard enough.
Well, and if you think about it, like some people, when we did the key informant interviews, they were so tired of having to fight for every little thing they've gotten made. Because they just can't handle it anymore. It's too much of a struggle. And that should be front and center in the government space, right? And sometimes yelling is important, right? And also that's why it was also when they did the Pay to Pee campaign in Ontario, it was embarrassing to them. Yeah. So a little bit of embarrassment could go a long way.
Well, and this is what we're frustrated with in Ontario is no one is telling us that our evidence is not sound. All our health economics, our research, and our proposals have all been accepted as we're no longer in the conversation around proving this to us. That we're beyond those discussions. Nobody's saying, well, let me revisit your research or let me relook at your economics. Everybody's saying all those are sound. The only 2 things that we have to complete is mechanism and how much.
Well, on that note, we've gone over by a few minutes. I just want to thank our guests. Thank you so much. Peter, if you can shoot me over those resources as well, Chris, if you
If you can start with our website, because it's all on our website. If there's a whole catheter section on SCIO's website, and you can pull the reports all from there. And then just connect with me, Terry, and we'll find out what all the missing other pieces is. We're due for another update. We have videos from urologists and of such where we can also share.
So is the website sciontario.com?
Yeah, sciontario.org.
.org? Okay.
It is sciontario.org.
Okay, awesome.
Awesome.
Well, thank you so much.
Thank you guys so
lots
much.
to think about. It's going to be a task, but like I told everybody, we should get on it, and I'm going to try and make it fun.
Yeah.
However we can do that, however you can make pushing for catheter support financially fun, I don't know. But I think if we can make it fun, we'll definitely get more involved.
Well, this is definitely the one to start with, for sure.
Yeah.
Well, good luck, and again, I'm happy to support anything that you guys are trying to do. My frustration is now to the point where I want to resolve everything in every other person's province, and then go back to my province and say, look, we've solved everything else everywhere else, and you're the only one left.
Perfect. That sounds good. Well, you can start here.
Thank you both so much for your time. Really appreciate it.
Thanks again.
Have a great day.
Christmas.
Thanks,
Thanks.
everyone.
Thanks. Bye-bye.
Happy New Year. Thank you.
Thanks.